Hello there, everyone. Welcome to this very exciting webinar where we're all going to learn so much in the next hour. Following the success of the Asian Oceanian Epilepsy Congress in Delhi, the highlights have been transformed to webinars, and for me, this is one of my special favourites. By the way, I'm John Dunn and representing our wonderful region, the Asian Oceanian region. This evening, we have the pleasure of hearing a debate, a vigorous debate regarding cannabis and its derivatives for the treatment of epilepsy. Are the benefits overrated or not? And we have a wonderful opportunity to learn from two excellent speakers who understand that not only is learning important, it can be fun. In fact, if it's fun, we learn so much more. And in a debate, a light-hearted debate with clever and entertaining and educational people like Helen Cross and Emilio Perucca, I know you're going to enjoy this, and I'm looking forward to hearing again and learning the pearls from these wonderful people. So I'll hand over to our chairperson to carry on. Thank you.
Thank you, Professor John Dunn, for your wonderful introductions. Good evening and good afternoon, everyone, for today's sessions. My name is Kamornwan Katanyuwong, a pediatric neurologist from Thailand and Secretary General of Epilepsy Society of Thailand. It is my honor to share in this today webinar sessions on a topic that sparks medical interest everywhere. And before we start, we will play a recorded video from the live AOEC Congress in Delhi, followed by a live rebuttal round later in the session. So it is now my honor to introduce our two expert debaters, both internationally recognized leaders in the epilepsy community. So the first speaker, Professor Helen Cross, she is a pediatric neurologist and epileptologist at Great Ormond Street, London, and she also leads the UCL Great Ormond Street Institute of Child Health, and she is the current president of ILAE. And her opponents, the other debater, Professor Emilio Perucca. He is now a clinical professor at the University of Melbourne and adjunct professor at Monash University. Previously, Professor Emilio is a professor of clinical pharmacology at the University of Pavia, Italy. And Professor Emilio Perucca is a past president of ILAE. Both Professor Helen Cross and Professor Emilio Perucca received many awards, and both of them has published scientific paper, more than 600 scientific paper. So before we begin and open the video, we are sure that you can see the poll before the debate already. And hopefully you have time to take a moment to answer the pre-debater poll. I think if you have any question during the debate session, please feel free to type and text your question in the Q&A chat box. I think we are ready, and let us now watch the main recorded video from February meeting featuring between Professor Helen Cross and Professor Perucca.
Very much. So, yes, I sincerely like to point out that we are good friends, as far as I'm aware, and hope very much that we will still be good friends at the end of this session. So, I'd like to put to you that the benefits of cannabis and its derivatives are not overrated. So where did all this come from? Well, it is some years back now, in excess of 10 years ago, that a little girl in Colorado who had Dravet syndrome, Charlotte Figge, was really having a really bad time, more than 300 seizures a day. And her mother was really researching, she was a scientist, she was researching about what might help, and decided to use an extract of cannabis oil. This dramatically reduced her seizures from 300 a day to 5 a day. And so, as you can see, it hit the press. A new miracle treatment for epilepsy. They then facilitated this, making an oil, Charlotte's Web, they subsequently called it, and the whole media frenzy started, and many thought, here we have the miracle treatment, and to be honest, that's what's given it a bad name. The cannabis-based medicinal products have had a bad name because they were sensationalized. But surely there is something in this. There was subsequently a parental survey, and this added the fuel to the fire in the sense that there were only 19 in this survey. But what was key was, yes, there was complex epilepsy. They'd all tried an average of 12 drugs before they trialed the CBD oil. But what was also interesting was there were certain benefits that were pointed out as a result of the treatment, not just seizure reduction, but better sleep patterns, increased alertness, and better mood. So I put to you that the cannabis-based medicinal products have led to an improvement in seizures where other anti-seizure medications have failed in a complex population. And there are also positive effects beyond the seizures that families really appreciate. So what about the improvement in seizures where other anti-seizure medications have failed? Well, of course, there are a whole range of cannabis-based products. And we're not talking about the consumer food products, which are sold over the internet. These contain very little in the amount. There's not consistency in the amount. We're not talking about that. There are non-regulatory approved cannabis-based products, and they have been utilized in parts of the world and may well be part of this. But of course, most of our evidence, true evidence, has come from the pharmaceutically approved product, pure cannabidiol, Epidiolex. And there have been a range of now clinical trials that have demonstrated with cannabidiol as add-on therapy benefit in really complex epilepsies. Dravet syndrome, Lennox-Gastaut syndrome, and also epilepsy associated with tuberous sclerosis. And with also open label continuation demonstrating sustained benefit, as I'll come to. Now, I presume that my esteemed colleague will try and make the argument, and I'm being presumptive here because I have not seen his presentation, that all the interaction that we have, namely that with other anti-seizure medications, it's what gives the benefit from cannabidiol. There's no question that early on in the trials, it was determined that many of the side effects we saw could be the result of adding cannabidiol to clobazam with the resultant metabolite normethylclobazam. Desmethylclobazam, also known as norclobazam. And yes, levels of norclobazam increased in many of those that were tested. So it was put forward, and this is how it became licensed, that cannabidiol needed clobazam in order to be effective. I argue that is not the case. If we look at the original Dravet study, yes, 2/3 of them, not surprisingly, it's Dravet syndrome, were on clobazam, but 2/3 were also on stiripentol, as well as also sodium valproate. And then other anti-seizure medications were also utilized. And I argue that actually cannabidiol, being a cytochrome P450 inhibitor, yes, it affects the levels of clobazam metabolites, but also metabolites of other anti-seizure medications as well. And in a study that was actually carried out before the randomized controlled trial in Dravet syndrome, in order as a dose-finding study, but was published subsequently, they looked at the fact of norclobazam levels in those where cannabidiol was added to their anti-seizure medication regime, including clobazam. And you could see that actually with the addition of cannabidiol, yes, on the left, norclobazam levels were increased. But in the presence of stiripentol, the norclobazam levels did not increase, presuming that there was a saturation effect, and therefore if they're on stiripentol and clobazam, you're not going to see that effect, and therefore cannabidiol must be acting as an anti-seizure medication on its own. This is the data from the tuberous sclerosis study. Yes, there's an added effect with clobazam, but there's still a significant effect with use without clobazam. And indeed, it was subsequently licensed for utilization in tuberous sclerosis without clobazam. Subsequent systematic reviews looking at those off clobazam and those on clobazam showed no difference in efficacy in cannabidiol, resulting in the overall conclusion that cannabidiol has an independent anti-seizure activity and efficacy irrespective of clobazam administration. And now we have publication beyond Dravet, Lennox-Gastaut syndrome, beyond tuberous sclerosis, of efficacy in other syndromes. This is a definite anti-seizure medication. And we have now evidence that it doesn't necessarily work on the endocannabinoid system. It has various actions at the neurotransmitter junction, various inhibitory actions that, again, mark it out as an anti-seizure medication on its own. So what about the positive effects beyond the seizures? My second point. Now, there's no question that in the cannabidiol trials, there were adverse events, but they were relatively minor and indeed could be got around by adjustment of other anti-seizure medications. Yes, there was concerns about changes in transaminases, particularly with use with sodium valproate, but again, adjustment to the medication alleviates that problem. So it's relatively well tolerated. And indeed, if we look at the retention in the long-term open label studies, and acknowledging 48 weeks is less than 12 months, you could still see that three-quarters of those in the Dravet study and two-thirds of those in the Lennox-Gastaut study were still on the medication 12 months after initiation of the trial, accepting that there were those that started with cannabidiol at the beginning of the trial and those who went on it at the end of the 3-month treatment period. So retention seems to be relatively good. And this can also be seen, acknowledging that 48 weeks is not that long. This study, utilizing a cannabidiol artisanal oil, and this is looking over a retrospective study, I acknowledge, but looking at different oils over that time. 73% reported improvement in seizure frequency at some point in that time. But retention, as you can see in the top right-hand graph, was exceptionally good, with around 65 to 70%, 72 months after the start of the preparation. Now, you could argue, is it all the seizures? Because only 48% showed more than a 50% reduction. Well, actually, they reported benefits on direct questioning on a variety of other aspects: alertness, communication, learning, language, sleep, mood. And what they also noted was that the effect was long-lasting in all of these, as well as the seizures, and were demonstrated early in the course of treatment at a lower dose, but sustained. In this study, where they used a transdermal gel in the treatment of epilepsy, again, non-randomized, but a controlled trial looking at before and after effects, they also showed benefits using prospectively specific questionnaires, looking at quality of life and also sleep scales. And you can see here that actually on the right, the p-values looking at before and after, the mean change, in all these aspects, seizure severity, behavior, mood significantly benefited, as well as improvement in sleep. And they showed improvements in social and interpersonal engagement and irritability in 77%, sleep, alertness and energy in 53%, and cognition or concentration in 47%. And in this, a more structured questionnaire interview-based study looking at carers of individuals who've been initiated on the pure cannabidiol, Epidiolex, in Dravet or Lennox-Gastaut syndromes. The blue is those that were spontaneously volunteered in the interviews, benefits in cognitive function, communication, behavior, leisure activities, emotional well-being, as well as impacts not only on the individual, but impacts on the caregivers. So the improvements in the quality of life seen in cognitive function, communication, behavior, mobility, and participation in daily activities. I am surprised that my esteemed colleague is putting forward that cannabis is overrated, because as an esteemed botanist, he has spent his time on the management committee and since trying to convince us of the merits of various plants, here instructing another esteemed colleague in Singapore on the merits of the various plants, trying to teach us the names, I have to say, and failing. So I'm a little surprised that he doesn't see the merits of yet another plant-based product and the way we should be moving forward. I put to you that cannabis and its derivatives, and namely cannabis-based medicinal products, have much to offer in efficacy, particularly in the early onset epilepsies. It's well tolerated, and there are benefits reported beyond the seizures. I appreciate difficult to quantify, but the consistency in studies means that there must really be a benefit. Thank you very much.
Yeah, the first video is completed and finished. And before we move to the second video of Professor Perucca, waiting for the video to be ready, Professor Perucca video, he will talk about cannabis and its derivative. It is overrated. So I think the video, if it is okay, please show the video. Thank you.
Well, I knew I should not have accepted this. I just have to argue that, yes, the benefits of cannabis are overrated, and I will have some arguments for that. You have my disclosure here, and I have an additional disclosure, more general, to make, and that is the outcome of the debate generally is not so much dependent on the merits of the arguments being debated as on the standing and the ability of the speakers to present their case. And with respect to the present debate, I think there are a few factors that we should consider. First of all, the current role of the two debaters in the ILE leadership, experience as standing as pediatric epileptologists, direct participations as PIs in cannabis trials, experience in designing clinical trials, and mastering of the English language. So I try to put some scores for that on a 5-point scale. Current role in the ILE leadership. Everyone knows Helen Cross, the president of the ILE. I wonder if anyone knows me. Not certainly many people in the younger generations in this room. Experience standing as a pediatric epileptologist, I gave 0 to myself because I'm simply not a pediatric epileptologist. I never participated as a PI in a cannabis trial, unlike Helen. I have some experience in designing clinical trials, not more than Helen. And with respect to the mastering of the English language, you can judge for yourself, but I think it's pretty obvious. So if you just do the mathematics of this, this is how we are starting the basis of this debate. That's why maybe I deserve 5 extra minutes. I already spent 5 to point out my disclosures. So I will just divide in my part of the debate on dealing with, briefly, with 3 points. Discuss the benefits in cannabis and its derivatives for epilepsy and the evidence based on randomized controlled trials. The second part is discuss how those benefits, which I believe after you've seen them, and Helen will agree, are the objective data, how those benefits are actually rated by users, and whether there is a discrepancy between those actual benefits and the expectations. And then, having argued that indeed the cannabis products are overrated, I will just put forward some reasons of why this is so. As I said, I'm not a pediatric epileptologist. I'm actually, initially, my origin are as a clinical pharmacologist. So give me just one slide to discuss the clinical pharmacology of cannabidiol. And for a clinical pharmacologist, cannabidiol is a nightmare. It's actually a rather poor drug overall. Very low bioavailability, less than 7% of what you are ingesting is actually absorbs and gets into the blood system. That itself is not so much of a problem. The problem is a huge variability in that bioavailability under many factors, including whether you take it fasting or with food. The bioavailability increases 4-fold when it was taken with food, but this was not actually controlled in the clinical trials. And the variability is huge, which may explain why some people appear to respond and some do not respond at all. The pharmacokinetics are a real nightmare. And to add confusion to this, drug interactions are very prominent in the actions of cannabidiol, and this has been already put forward, acknowledged by my esteemed opponent. So in just one slide, I'm summarizing the data supporting the efficacy of cannabidiol in the 3 approved indications, Dravet, Lennox-Gastaut, and tuberous sclerosis complex, showing the median percentage change in seizure frequency from baseline at the 2 doses that have been tested, 10 and 20 milligrams, and placebo that was included in all those adjunctive therapy trials. And indeed, in each trial, cannabidiol was superior to placebo. And the largest difference was actually in the trial where Helen Cross was a key participant. And in that trial, the responder rate to the response to cannabidiol was 39%, a reduction in seizure frequency, compared with 13% in the placebo group. That was the largest difference between cannabidiol and placebo seen in any trial, in the trials that were done. But the actual benefit, you will agree with me, is actually not 39%. It's 39% minus 13%, which is that group in the assigned to placebo, which is actually 26% overall the net advantage, the net increment in benefit brought by cannabidiol over placebo. So I'm not arguing there is a benefit, and the benefit is in the order of 26%. Please remember those numbers, because we'll come back to that in a moment when we look at the perceptions of the efficacy of cannabidiol. Let's make, and I admit, this may not be a fair comparison, because for a fair comparison, we would need head-to-head trials. We don't have those, so that's the best we can do is to look at how people have done in trials with other drugs which have similar indications. And let's look at fenfluramine. These are the trials, again, same outcome, percentage of patients with at least 50% seizure reduction, and in Dravet syndrome, pretty obvious, the outcome of fenfluramine versus placebo was overall much, I would say, overwhelmingly better compared with the outcomes in the cannabidiol trials, consistently throughout the trials. And in this specific trial, 73% in the high-dose fenfluramine group responded, compared to 6% of a placebo. So not a 26%, but a 65% difference in magnitude of response between the active compound and the placebo. In Lennox-Gastaut, the difference was not so great between the 2 compounds. This is tirapentol. The difference with the outcome measure in this slide is not that the other slides reported patients showing at least 50% seizure freedom or median percent reduction in seizure frequency. This is actually percentage of patients who were completely free from seizures, admittedly clonic, tonic-clonic seizures, and only for the second month of the trial. But 43% of patients on stiripentol were free from seizures during that month, compared with 0% on placebo. So, and that was not me. Renzo and some other colleagues did actually a network meta-analysis, which I acknowledge again, it has many limitations, looking at 2 different doses of cannabidiol, plus fenfluramine, plus stiripentol over placebo, looking at 50% reduction in mean convulsive seizure frequency. This is cannabidiol 10 and 20, better than placebo. I'm not arguing with that. Significantly better than placebo, but also marginally better than placebo, and very, very different from the outcome with fenfluramine and stiripentol. And this is in terms of 100% reduction in seizure frequency, seizure freedom rates. For those estimates, cannabidiol was not different from placebo. Fenfluramine was, although the effect was marginal, stiripentol was, and by some margin compared with the other drugs. What about tolerability? Because we said benefits, but also discontinuations due to adverse effects is a hard measure. And if we look overall in the trials to patients randomized to cannabidiol, to different doses of fenfluramine or placebo, you will notice, especially looking at 95% confidence limits, that for cannabidiol, there was a trend for discontinuations to be more frequent with placebo, and that also was fenfluramine, but that was not significantly different. For stiripentol, actually, discontinuations for adverse events were greater in the placebo group than in the stiripentol group. However, when we look at patients who were also on clobazam, the only drug in those trials which was worse than placebo in terms of tolerability was cannabidiol at the dose of 20 milligrams, largely due, and my esteemed opponent has already mentioned that, to the interaction with clobazam. So taking all those data, and here again is a different groups of colleagues, so not myself, I say was rather unbiased from different parts of the world. So when they put together, based on objective data, an algorithm for prioritization of treatments in the management of Dravet syndrome, which is condition that responded best to those compounds discussed so far, they say valproate should be the drug of first choice. Then as second choice, you may go for fenfluramine, you may go for stiripentol, you may go for clobazam, and cannabidiol only comes in 4th position in the treatment argument. So my argument is not that cannabidiol is not effective. My esteemed colleague thought I would argue that. I'm not going to argue that. I'm simply going to argue that it is overrated. I'm not arguing that it isn't effective. It is better than placebo, but the effectiveness is overrated, and I will expand a little bit more on that. I fortunately don't have to go through this because Dr. Cross has already told you that there is an interaction with clobazam, which is significant in every single patient on clobazam to whom you give cannabidiol. The blood level of clobazam, which is the main active metabolite of clobazam responsible for the effectiveness of clobazam in these patients, it goes up. When you see that it goes down, is because of adverse effects. The dose of clobazam is reduced in individual patients. And based on those data, this is not me, this is a group of clinical pharmacologists that they put all the data into a computer, and the response of the computer was that cannabidiol is a parasitic drug, meaning, that's the terminology they use, that its efficacy is due to its ability to increase the levels of the active metabolite of clobazam, and therefore, what you achieve with clobazam, you can easily achieve by increasing simply the dose of clobazam without the added expense and some independent side effects due to cannabidiol itself. I'm not going with that. And in fact, if you look at an analysis of the individual data from different patients, going back to the regulatory data, which have been made public, and this is what we did in this publication, we came to the conclusion, looking at the response in patients who were not on clobazam, and this is the last point, putting together all the studies done with cannabidiol, both in Lennox-Gastaut syndrome and Dravet syndrome, putting together all these populations, that was the only way we could show that cannabidiol was better than placebo. Marginally better than placebo, absolutely marginally better than placebo, and only doing that by putting together all patients irrespective of diagnosis and all doses of cannabidiol. But if you look at the individual trials, there was a trend, but this was not significant for cannabidiol to be better. So I'm not arguing. It has an independent effect from clobazam, but it is a marginal one. I will not discuss other products of cannabidiol because my esteemed opponent has already acknowledged that the evidence about efficacy of the non-pharmaceutical grade formulations is practically non-existent, so I don't have to spend time on that. So that's about the objective data, about the efficacy and tolerability of cannabidiol. What about how those benefits that I'm sure all of you are familiar with, that you were familiar with before this debate, how those benefits are being rated by users? And this is a challenging part of the debate. Rated by whom? By Dr. Cross, by our esteemed umpire, by different people in this room, rated by the media, the users. Everything is very subjective. So how can we say is overrated, is underrated? I think you get a different answer everyone does too. There is a different way to assess perceived benefit, and that is the extent of clinical use. This is objective, but is also very subject to confounders, including differences in availability, accessibility. So we say a few words about this. And unfortunately, clinical studies assess the value of a treatment, but not how the treatment is rated by users. So I thought, okay, let's look at how, because there is a debate here, so how the institute of my esteemed opponent is rating cannabidiol. So I went last month to the Great Ormond Street website, and which gives a brief summary of the trial in which Helen Cross participated, and I've shown you the results earlier on in my presentation, and this is summarized like this. The results were extremely positive. Would you agree with that? Nearly 40% of children with Dravet syndrome responded when compared with the dummy drug. Yes, but there is no mention that the dummy drug had a 13% response. So the actual benefit, as we discussed, was 26%. But this is not mentioned here. And I thought Dr. Cross might perhaps have this announcement disappear in view of this debate. So I checked it this morning, and it's still there. So let's look back at perceptions. This is a survey of perceived efficacy of cannabidiol-enriched extracts in pediatric epilepsy in different groups. It's in early publications. What you can see is that looking for infantile spasm, Lennox-Gastaut syndrome, the overall percentage of patients showing a perceived benefit, which is very ambiguous, I acknowledge, more than 80%. For Dravet syndrome, more than 60%. For all others, again, more than 80%, overwhelming positive results. And I left for yourself to compare the result of this perceived benefit versus the objective data that we saw before. And it's interesting to look actually all others includes focal seizures. In fact, a randomized control trial has been done in focal seizures because the perception of benefit is so pervasive that people think, okay, cannabidiol is a broad-spectrum drug. It works in different conditions, seizure types, even focal seizures. A trial has actually been done. Admittedly, not the Epidiolex formulation, the transdermal cannabidiol formulation in adults with focal epilepsy, and the outcome was negative. Cannabidiol could not be distinguished from placebo with respect to efficacy. My esteemed opponent will say, okay, but this was transdermal cannabidiol, it's unfair. Okay, it's unfair, but if you look at the last line here, the levels of cannabidiol in the blood in this study were comparable with those seen in children given cannabidiol in the Dravet syndrome trials. So it was not because this formulation had a problem with getting absorbed. The drug got well into the bloodstream. Simply, it did not work. Focal seizures, admittedly. In spite of the fact that the benefit is marginal, there is another way to assess the way it's perceived, how often people use it. And despite of the fact that fenfluramine in the United States, because the data here are mostly driven by the sales in the United States, in spite of the fact that fenfluramine is more expensive, if you look at the sales of cannabidiol, as I said, this is mostly US, $845 million in 2023. Poor fenfluramine, despite of those efficacy data, only $226 million. I think there is something which here does not match the data that we saw before. And again, let's look at expectancy versus experience. This is a study from Germany. Look on the left side here, efficacy in people who have not tried cannabidiol, and look at expectations in terms of you expect the drug to be worse or better than other drugs. And you can see 70% of people who never tried cannabidiol expected cannabidiol to be better than the anti-seizure drug for childhood epilepsy, the other anti-seizure drugs. However, this is expectations. Look at people who actually tried cannabidiol and look at the experience on the right. Equal numbers, worse, equal, the same, only 1/3 conclude it is actually better. Again, look at tolerability. Let's look at not the expectation, because this is the same in group who never tried it, in people who experience it. Everyone expected cannabidiol to be better tolerated than the other anti-seizure drug. But when you look on the right at the experience, you will see that there was a significant proportion that found cannabidiol to be worse tolerated. And that expectation was not there in people who had not tried cannabidiol. Okay, let's just come to the conclusions from that study. There is a huge interest in cannabidiol, which include potentially, and this is not me, this is my German colleagues, potentially unrealistic expectations of its efficacy and tolerance compared with the low level of information. And I will not spend more time on this. Let's move from Germany and those who are patients to neurologists. And here we are in Canada. Proportion of neurologists considering cannabis for different indications, 70% for Dravet, 64% Lennox-Gastaut. But look here, 27% for idiopathic generalized epilepsy. What is the basis for considering in the treatment of your patient with IgE cannabidiol? And 18% for focal epilepsy, and you have seen the data. So you see there is huge discrepancy between what the objective data are and what people perceive. I have lots of slides like this. I just picked one because it's from this region, and I thought our umpire may appreciate seeing the data from her own country, Thailand. A study in 199 parents, caregivers of children with epilepsy in Bangkok. 9% reported having used cannabidiol. About 1/2 reported the child had less seizures. None was seizure-free. Cannabis was obtained by 4 healers by 31% of the cases. 81% of respondents did not know the cannabidiol is the active principle, and 90% were not aware of side effects. And despite of the lack of knowledge, 77% were eager to participate in cannabidiol trials. So there are huge expectations, huge enthusiasm about this drug, in spite of the data, which are not so great. And I will just close to just putting forward, and this I admit is the only part of my presentation where is speculation about reasons of why cannabidiol may be overrated. I think is overrated by people with epilepsy. And partly, and I thank my esteemed opponent for actually helping me with this, partly because of the way cannabidiol was brought along, huge impact of the media. It's a drug that does beautifully in the media, partly because, and we go back to that in a second, it's not just a drug like others. It comes from a plant, and a popular plant for many other reasons, and the history of Charlotte Figi that we heard that before. And again, let's, okay, 2 minutes more.
Sorry.
Go ahead, 2 minutes.
You have 20 already, so I give you 1 minute more.
Okay, 1 minute only. Well, it's really rigorous empire. If you look on Google, cannabis and epilepsy, 3.7 million hits. Cannabidiol in epilepsy, more than 1 million hits. Fenfluramine in epilepsy, 49,000 hits. Clearly huge discrepancy in the popularity and the attractiveness of natural products. They are generally perceived as being healthier than synthetic medicine, little awareness that natural products can be harmful. When asked, and this goes to, again, patients from Germany, would you prefer to take a plant-derived cannabidiol or a synthetic one? Look, 70% want it from the plant, only 5% synthetic. They think coming from the plant is magic. Even if it is the same substance as pure, but from the laboratory, they don't like it. And why you prefer it from the plant? Because it will be better tolerated, because it does not contain chemicals. It's just magic, no molecules there, just magic. Fewer and less dangerous side effects. But still remember, and I don't have to convince you because you're all physicians, that plants are sources of many medicines, but medicines are poisons, and actually plants are source of many dangerous poisons. And here is a small collections of beautiful flowers which contain lethal poisoning. So the conclusions, unlike my esteemed opponent mentioned, I was not going to argue, I'm not arguing that cannabidiol is ineffective. It is effective. It's an effective anti-seizure medication in a subset of epilepsy patients, only within the approved indications. However, the efficacy is modest, largely, not exclusively, acknowledged, mediated by interaction with clobazam. Its popularity is disproportionate to the actual benefits, and many factors contribute to this attractiveness. And this, I thank you for your attention. Thank you.
So thank you to both Professor Emilio Perucca and Professor Helen Cross for the first round, dynamic and engaging exchange information from the recorded video. And we are fortunate to have them here with us for live today for a short rebuttal round. So I would like to invite Professor Helen Cross to open the video first. And let us begin with Professor Helen Cross. You have 5 minutes to add on information on your topic. The floor is yours, Professor.
Thank you very much. And yes, it was very nice to hear you again, Emilio, outlining all your arguments against the title. I didn't think it was necessary really to point out your perception that you were at a disadvantage because people wouldn't know you. I think that's highly unlikely. And your command, Emilio, of the English language is probably superior to mine. So I'm afraid I don't buy that, actually. And, you know, I think you did argue, however, that, you know, how do we judge what is overrated? And I think what you illustrated, and as I illustrated, is that cannabidiol is beneficial in epileptic seizures. The issue is who is the judge as to whether it's overrated or not. And I acknowledge that perhaps plant-based medicines have, there is a belief that they may be safer or they may be better than others. And that may lead to the bias. But again, it's all a matter of a subjective, objective view. I do, however, feel it's a little unfair to compare cannabidiol to the efficacy in fenfluramine and Dravet syndrome. Particularly if you look at cannabidiol studies, their effectiveness with no specific mechanism of action targeted at a specific type of epilepsy, then you see an effectiveness in randomized controlled trials to the same percentage probably over placebo as you've seen in other medications, and actually superior to what you would see and you demonstrated with fenfluramine and Lennox-Gastaut syndrome. If you looked at the difference between the effect and the placebo for the Lennox-Gastaut syndrome, it was only 18%. So in Dravet, we acknowledge there may be a very specific benefit because of the mechanism of action, because of the serotonin action, and therefore to compare cannabidiol and fenfluramine, I think is a little unfair. We need to look at it versus other anti-seizure medications. And the only reason it's been looked at in Lennox-Gastaut, Dravet, TSC, is because of the perception that if we look at it in orphan conditions, then maybe we ought to spread the applicability, but that hasn't happened because of expense. So nobody's ever specifically said that cannabidiol is only effective in these epilepsies. It's the fact that it's the way the clinical trials were designed. And I think you also acknowledge that it's well tolerated. And there is the issue about possible benefits, which are difficult to quantify, possibly due to the fact that it's not sedating, whereas other medications may be sedating, may be perceived to have benefit and behavior issues. Maybe this is not seen in cannabidiol, which is why parents, families are keen to keep those medications going. And ultimately, also, my other question of what you present, however, is that, you know, you compared the expense of what had been spent on CBD as opposed to fenfluramine in 2023. Cannabidiol had been around a lot longer than fenfluramine in 2023. There was probably a lot more experience. It was being utilized much wider than Dravet, Lennox-Gastaut syndrome, whereas fenfluramine in 2023 was probably only being used in Dravet syndrome. So again, I think it's difficult to look at expense and extent of use because of dependent on experience. So although I acknowledge there is a keen perception of the public out there that natural products are obviously better than non-natural products, and that is a misperception, I have to say, as you well illustrated, it doesn't mean to say that there are merits from current cannabidiol. And, you know, again, judging or acknowledging where do you call underrated, overrated, I think we have to acknowledge that cannabidiol is beneficial in the epilepsies and specifically those that have been trialed.
Well, thank you, Helen. Kamornwan, am I allowed to give my rebuttal?
Yes, now, yeah. Professor Perucca, you have 5 minutes, okay? Yeah, please go on.
Thank you. Actually, I have to start with apologizing because in listening again to the debate, I realized that I took so much time. So what I can do now is just to try to rebalance it, is just to take just a couple of minutes rather than 5 in addressing your last points, Helen. And in fact, you know that at the end, we were going to agree on those points because the key point is all drugs are beneficial, at least those coming into the market these days. Otherwise, they would not be approved because they all undergo rigorous clinical trials. This has been the case for all the drugs that we've been discussing. Cannabidiol is beneficial. I think the two of us agree that you just mentioned that at least in Dravet syndrome, the evidence is in cannabidiol being probably not as beneficial as other drugs, as pointed out also by the guidelines produced by a number of organizations that do not rank it in the prioritization scale as high as some of the other drugs that are used in Dravet.
in other indications, especially in those where cannabidiol is also approved, probably there is no particular signals indicating that it is any better or any worse than other drugs that are indicated in those conditions. So the key message is that each drug that we are using has some benefits in some patients. It's frustrating that we are unable to predict which patient will do better on one or the other. And so we have to go by a trial and error approach. And I also acknowledge, starting with your first patient with the magic results in Charlotte. I mean, that drug in that patient, and occasionally in some patients, is a miracle drug, same as other medications for reasons we don't understand turn out to be miracle drugs for that individual. Unfortunately, the overall results in a population with such difficult epilepsies are frustrating, and we still need better drugs than all the others that we have available. So I apologize again for speaking too much. But I think at the end of the day, we all agree. And I saw there were some questions in the chat, so maybe Kamornwan can, the two of us can discuss those. There were some interesting questions that I saw in the chat. Kamornwan, back to you.
Okay, thank you very much, Professor Perucca. So the rebuttal complete. And I think this debate has offered you more clearer insight into a complex topic. And so we have time for questions and answer. And I will select and ask Professor Perucca and Professor Cross to answer the question. So I think the interested question from Dr. Keota Kepbashi. So he or she asked that, what's about the other syndrome like infantile spasm, Rett syndrome? So any role of cannabidiol? So I would put this question to Professor Cross.
I think what's difficult is that, yes, it has been used on an anecdotal basis on many different syndromes, and in some cases been found to be beneficial. The issue is the clinical trials have only been undertaken in the very specific syndromes that we've talked about, and by that I mean randomized controlled trials, such as in Dravet, Lennox-Gastaut syndrome, and epilepsy with tuberous sclerosis. But we know that from compassionate use and from open label studies, it can be seen to be beneficial in others. There was a trial in infantile spasms, which actually was abandoned halfway through because it was showing no particular benefit. So there isn't evidence that it affects that, but in some of the other DEEs, there's no reasons why it shouldn't be trialed and utilized because there does seem suggestion in some individuals it can be helpful.
Yeah, so I will ask one question that related to Professor Kauta. So I'm interested in terms of the patient with virus. So I will ask Professor Cross and Professor Perucca that can we use cannabidiol in adjunctive with other medication to treat virus?
Yeah, so this is febrile-induced refractory status epilepticus that is a form of Norse, but fever-induced. And yes, cannabidiol has been used, but again, reported in anecdotal cases. And sometimes we find it helpful, and at other times it doesn't seem to be of benefit at all. Again, does it have a specific benefit? Well, you could say there may be some anti-inflammatory properties, but really we don't have, there is an algorithm that I think there's now two that a consensus group has put together with considering treatments in fires, and cannabidiol comes there, but it's not early in the treatment.
Yeah, Professor Perucca, could you please share your thought on this issue?
No, I simply have to endorse what Professor Cross has said. It's, I mean, we don't have controlled trials, but also we don't have controlled trials for other drugs. Based on what we know from the mechanism of action, we don't really have a specific reason for using cannabidiol before other medications in this condition, but in patients who have not responded to what are usually the first-line medications there might be room for a trial there.
So, okay, thank you very much for the answer. So, Dr. Anas Alasayed, so I'm sorry if I pronounce your names incorrectly. She asked about, is there any study that using CBD as a single drug? So,
So,
Professor Cross and Professor Perucca.
so this is, I mean, well, do you want to start?
Go
Emilio?
ahead. Go
Well,
ahead,
I think,
Ellen.
yeah, the issue I suspect is around monotherapy and how monotherapy is classified as, for pharmaceutical purposes, is starting as first-line medication. And no, there aren't studies with regard to that in any condition. But, you know, monotherapy in clinical practice means single drug therapy, whether they've been on drugs before or not. So if it's been effective, then we may withdraw other medications so that they may be on single therapy. Although I'd have to say most of my children, if not all of them that I have on it, are on at least one other medication.
Well, nothing else to add except that we do have experience as single therapy in animal studies, of course.
Yes, of course.
And in animal studies, you do see efficacy as an anti-seizure drug in some animal models of seizures and epilepsy. So that evidence justified eventually the conduction of clinical trials in patients, and we have seen the results. So I think there is little doubt that the compound is efficacious. The key issues is that we don't have good comparative data in many conditions.
Thank you. So I think the other question, perhaps maybe the comments from Dr. Janine Winterbottom. So she text on the question and answer box that the trial by social media will be the challenge for managing perceptions of benefit. The question is, for its use in the wider epilepsy population, trial for use in specific seizure types, focal or generalized onset seizure, in pragmatic head-to-head comparison, randomized control trial. So, do you want to add any comments on her text?
Well, we need more information about efficacy. There's no doubt about it. And there are trials ongoing, and the trials planned, both in early onset epilepsies, broad DEEs, not individual syndromes. And also there's an issue, the ongoing question from many is, does THC, tetrahydrocannabinol, add anything to the cannabidiol alone? And there are trials planned to look at that, and also the safety of adding THC on cognition and brain development. So these are all studies that need to be undertaken. The challenge is finding the appropriate product. And the trouble is, many of the companies are already earning a lot of money from utilization of these. So, you know, these studies will be done, but it's going to take a while.
Yeah, I agree fully. And also in the way of future research, there could be scope in developing derivatives of cannabidiol with a better profile, starting with the better pharmacokinetics. And there could also be different formulations, and some are in development right now, different formulations that manage to stabilize, reduce the variability and improve the overall absorption of cannabidiol. So that's also another way by which we could make progress.
Yeah, I think I can see another question that very important. So the question is, why does CBD alone continue to monopolize the cannabis space, given to other legions of cannabidiols or terpenes in cannabis? So I think this question for Professor Perucca first, and then Professor Cross.
Well, I already mentioned it. I mean, there is an interest in other compounds, other derivatives. I mean, one cannabidiol has already undergone clinical trials. Results were not very, very promising, in fact, and eventually development was discontinued, at least in the initial indication the BG was tried. Other drugs are in development. and preliminary results are promising. So there may well be other derivatives that will prove to be efficacious and of value and best complementary to cannabidiol itself. And also, and Helen has already touched on that, the combination of, for example, THC and CBD and also other combinations as well, because there are lots of pharmacodynamic interactions at play here when we are using these drugs in the DEs, and we need to characterize them better in order to use these drugs more rationally.
Yeah, I don't have anything really to add to that, apart from, you know, the fact is that you'd say, why has cannabidiol got the monopoly? Well, it is that there is only one pharmaceutically sold proven product that's licensed that has been available. Many of the other products, the cannabis-based medicinal products that are available may be GMP, but they're not necessarily pharmaceutically prepared, and therefore have not been available through the same routes.
Yeah, thank you very much. So I try to pull the poll, pre-debate and post-debate, and we'll see after these sessions. Okay, somebody still support to use the cannabis treatment for epilepsy, 36%, but some still undecided. And for another question, that the public perception should influence national policy about use of medical cannabis. So I think the audience agree that significantly that the public perception should influence the national policy. So this is the poll of today. So because of we have time limited, we spent 1 hour already, and I hope the debate session offer the audience very clear insight. And I think we can all agree that no need to vote for the winner of the debate. Okay, so if no one would like to add more information,
Oh, I
would
think
like
that Helen has been very convincing, because you have 1/3 of people who are now more supportive.
let me
So-
see.
I think it's very clear that we actually both agree.
Yeah.
You know, this is for the purpose of
Okay,
the
the post debate poll pull out already. That okay, yeah. So, Professor John Dunn, would you like to say some word before we close the debate session for today?
Look, only to say, look, you've been a wonderful chairperson, as I expect, to our educational and entertaining experts. And this is how we learn, because it's fun. And debating, I've always enjoyed both of you speaking so well, and tonight's not an exception. So thank you very much.
Thank you.
Thank you.
Thank you,
Good
Helen.
night.
Thank you,
Yeah.
Kamornwan.
Thank you, Emilio.
John.
Nice to see you all. Okay.
Thank you, everyone.
Thank you.